Hi everybody, this is the video for week 4. I'm doing this just this week instead. I was going to do 3 weeks at a time, but my voice may give out on me and I'm trying to get this done relatively quickly. I will promise I'll get ahead of the following week's more timely manner for next week, but this is just for week 4. So this is the duty of care and professional negligence week. This is one of my favourite weeks in terms of the subject. It's got a lot of good stuff to be talking about, and one of the most important weeks, I think. There's the introduction stuff, regular things here. We're going to understand the concept, duty of care, and the conditions for action of negligence, and connecting the two concepts of duty of care and negligence together. And then we're going to look at the scope of practice. And scope of practice is really important because it's one of the learning outcomes. It's not really all that well woven into the other topics, and they have to answer a question about it in their major written paper in assessment 2. So it's important that they've got a good grasp of the concept. And last year, the scope of practice is something they just generally didn't understand very well. So it's important that we've gone through that well. Activity 1 is the practice exam, so I'll send that through to you as an email. Please give them the sheet, so it's a two-sided page. Hand them out, give them 10 minutes, ask them to be quiet and to do it as an exam conditions with no phones and no computers and things, and not speaking to each other to distract each other. They're allowed to keep the sheet, that's fine. Please don't give them more than 10 minutes, don't give them half an hour or anything because they want to keep practicing. They're quite welcome to take the sheet home. If they can't do the questions in 10 minutes, I've tried to aim it for roughly what the sort of speed they'll need to go in the exam. So they need to speed up and then to go back and review the content if they can't answer those questions in 10 minutes. I would suggest. So I've got some suggestions around preparing for exams. You might have some students in your group that haven't sat an exam for a really long time. If they're full-time students, they've probably done BMS, but if they're not, it's possible to be doing this subject without having done an exam at all in this course. So just be aware that some of your students might not have done exams for a really long time. So there's some suggestions on how they might go about managing exam stress. Activity 2 goes for 20 minutes. This is duty of care and negligence conceptual review. So this is going through what they should have read about in the textbook and also in the lecture and stuff. So the first question is, what is meant by duty of care? I've sort of gone through the textbook and found a few little comments, but mainly I've talked about it's something that one person owes another person, and in the health context, it's the care that's owed from the patient, from the nurse to the patient, and also to visitors and relatives and students that might be present as well. It's important in this question to distinguish between care, the care that's provided by nurses, and what the law actually refers to as duty of care. So I mentioned things like restaurateurs have a duty of care to the patrons that are buying their food. The duty of care refers to more about being careful and being, taking a considerate approach to things rather than providing health care. It's not a health care phrase, it's referring to being careful. So the duty of care to take appropriate consideration when you're doing something. So for nurses, that would refer to following the 5 rights and that sort of stuff, to be limiting yourself to your scope of practice, to be obeying laws and legislation. Basically the whole thing that we've done up until this point is all within the duty of care of a nurse towards the patient. It's also the underlying concept behind civil negligence, which is written in their book. So failure to meet the duty of care, if the plaintiff can prove the person had a responsibility to avoid harm, will make the person liable for negligence. So there's a connection between the duty of care that one person owes another person, and then if you can demonstrate that you failed that, then a couple of other things that we're going to look at in just a moment, then that would be a negligence case. You need to practice to a level that would be widely accepted as a standard. So expert opinion, policies and procedures, legislation, codes, practice standards, generic and specialty specific stuff. So I gave them some examples last year about the RN standards of practice that they might be not that familiar with, and referred to that as being a standard. I also talked about if you work in theatres that you work towards the ACORN standards, and doing things in theatres that don't adhere to that would be falling short of an accepted standard. I also talked about later on in the subject we'll be looking at cases where they ask for expert opinion to refer to would you have expected a nurse in this case to have done X, Y and Z, so that lecturers and people in governance can be asked to come along and give expert evidence as well. And I asked them to think about the role of the registered nurse in terms of how they're being hired. They're not being hired as a so moving on to the next question, what professional, legal and ethical standards are used when the actions of a nurse are being considered? So there's those standards, but also that registered nurses are hired as a critical thinker. They're not employed as enrolled nurses, and employed as AINs. That the distinction with a registered nurse is that they're being asked to use their brain, that they're required to be autonomous health professionals who challenge orders from doctors if they don't make sense, who are willing to ring up the supervisor and say, that's not safe, we can't do that. You are required to do those things even if it's scary. So I talked about that sort of thing in the duty of care as well. So yeah, we're pulling apart the ethical legal standards. So you've got RN standards of practice, you've got the code of conduct and code of ethics, you've got the ethical principles, you can reinforce those, and we've looked at them in the previous weeks, and the legal standards as well. You can talk about the main laws that we've already looked at, and you might ask them to quickly discuss the laws that they've included in their paper. They might be able to bring those up as well in paper 1. The next point is, what are the legal principles of negligence? It's really important that they understand these 4 things. They'll almost certainly be asked to recite them in the exam, and more importantly, they'll need to be able to apply them to cases. So we're going to have a practice at that in one of the activities, but they need to understand this stuff backwards and forwards, similar to the consent week we've just done, where they need to be able to tell me the 3 elements of valid consent. They need to be able to tell you the 4 parts of negligence. So the first part is that the defendant owed the plaintiff a duty of care, and we talked to them about, that if you're a registered nurse and the patient is in your hospital, that you already owe a duty of care to that patient, that you are part of the healthcare team looking after them, regardless of whether that patient is actually allocated to you for the shift or not, and how that changes depending on whether you're walking into work with your uniform on, or whether you're at home, in a supermarket without a nursing uniform, on how that duty of care changes depending on the circumstances. So in a negligence case, it's quite clear cut if a nurse is in a hospital or in a health setting working at the time and the patient is under their care, then obviously a duty of care exists. Second point is that they need to prove that the defendant was in breach of the duty of care by failing to deliver his or her professional standard that should have been existing. So they work out what the standard is, and we just talked about that in the previous question, and then they determine was the care up to that standard or below it. So that's pretty straightforward, and I think Amanda talks about in her lecture around that those 2 things happen quite a lot, that those first 2 elements are fairly easy to prove. It's the second 2 elements that become a lot more difficult, and a lot of reasons why civil negligence cases get knocked over. So as a result of this is the third part, as a result of the defendant's negligent act, the plaintiff suffered damage and loss. So they need to prove there's a connection between the negligent thing that the nurse did and then the outcome from it, which is a really difficult thing to prove in a lot of circumstances. So I point out to the students the difference between if a person has a cannula infection, that the number of people that would have handled that cannula makes it very difficult to prove that it was one particular nurse who is liable, because other people have handled the cannula, and we don't know when the infection would have been picked up. They may have, other people have accessed it with different devices and things, and you just don't know who it was. And examples like if a person dies as a result of poor care, but they were very unwell anyway, and there were other things that might have led to their death, the difficulty of pinning it on that one point of negligence is quite tricky. So sometimes it might be a contributing factor, but they really need to prove that it was a result of the negligent act that has caused the damage or loss, which is hard to do. The final part is that the damage or loss that the plaintiff is complaining of needs to be reasonably foreseeable, means that it needs to be reasonable that you could have asked that nurse in that situation to have known that at the time. So sometimes bad things happen and it's not foreseeable at the time, and the nurse wouldn't be liable under that act. But if you would ask a reasonable nurse at that level of experience, would you have expected, if you didn't put up fluids on a person that desperately needed fluids, would they have become more hypovolemic? And the answer is yes, of course I would expect that. Then that's the foreseeability aspect of it. So it needs to be something that you could expect that person at the time would have known. And that can be difficult to prove as well. So they're the 4 elements of negligence. The law you'll find that is in the Civil Liability Act of 2002. under the Act, so it's important to go through the defences as well. We've got a general denial, so that the nurse can argue any one of those 4 principles above. They can say that they didn't owe the patient a duty of care because they weren't involved in their care or whatever. They can try to argue that point. They can argue that there was no relationship between the care that was not given and then or the issue with the nursing care and then what happened to the patient. That's the 3rd point. They can argue that it would have been unreasonable, all those sort of things. Everything I just mentioned before is the points. They can argue any of those. So that's a general denial or rebuttal of the allegation. They can argue contributory negligence, which is where the patient was partly to blame, which I'll talk about in a moment. And they can talk about voluntary assumption of risk, where the patient gave informed consent. So if something bad happened that really shouldn't have happened, was still below the standard, but the patient has had valid consent and consented to something, then that's one potential defence for civil negligence as well. Then we come back to the Babish-Shah case and apply those principles to a case that they're familiar with that we looked at in week 1. So it's exactly the same story from week 1. Then I've just got a picture of the lactulose, and I've started to get a little bit more specific because a lot of them are doing NRS123, so they're starting to look at medications and all that sort of stuff anyway. So I've got a picture of the lactulose, and I haven't shown them what colour it is on purpose, but it shows them that it's a bottle of liquid. And ask them to read the story and then say, does this nurse owe the patient a duty of care? Yes, of course they do, because he was the nurse that was looking after that patient on the day. So there's no ambiguity that he had a duty of care. What professional, legal and ethical standards would you expect to be applied in this case? So the legal standard was the national law. As a registered nurse, he's breached that. As the Poisons and Therapeutics Goods Act would probably refer to some of that stuff from a medication point of view, and the regulation that sits underneath that, so the Poisons and Therapeutics Goods Regulation would be relevant. Therapeutics Goods Regulation, I think it's called, sits underneath that. Then we've got ethical standards around autonomy, as in you could address the patient's right to consent because he hasn't actually given a valid consent. He didn't know what was involved in taking that medication. So there's an autonomy risk. But the most obvious one is obviously non-maleficence, the nurse's responsibility to avoid harm, and he hasn't done that in that case. You can also talk about the main part, I think, would be the professional standards and starting to look at the New South Wales Health medication handling policy, which we're going to look at a lot more detail with the medication week when that comes up. But the standards that are built into that, the nurse obviously would not have met that standard of the SAFE principles. They're called the SAFE principles of medication administration. He hasn't met all of those, so that would be an issue. Then I've asked them to look at the principles and work out which ones apply. So would he be liable? Was there harm? Was there a duty of care? Did his standard fall below that? And I've already looked at that. And then the last 2 points as well. Would it be reasonable to assume that the patient vomiting and being very unwell was connected to him giving him dishwashing detergent, which is pretty clear? And also, would it be reasonable to expect that the nurse should have known that was what was going to happen? So I would say yes, he would have been liable under the Civil Negligence Act, under the Civil Liability Act. To further explain the case, I've gone through more detail just to sort of talk about the perspective of, because it's not as unreasonable as it sounds. It sounds pretty odd that a patient would just swallow dishwashing detergent. So the patient thought he was taking lactulose, which he wasn't, but the patient had previously been given lactulose in hospital. And the nurse thought he was giving cardizem, which was what was written on the bottle, which is a reasonable thing to think. And he was checking that against the medication chart. But it's helpful to explain to the students to some level that the 5 rights weren't really covered very well, because he should have been looking at the dose. He should have known that if he's giving a random volume of liquid, that wouldn't really be an appropriate amount, even if it was the right drug. He can't just start pouring some into a cup and give it to the patient. So that's really where he became unstuck. But I've got pictures of the liquids here that I took a photo of, because I think you can build a conversation around contributory negligence towards this, around it's completely unreasonable for a patient to have swallowed the colour in cup C. If he's had lactulose before, he really should know that it isn't fluoro green. And you can, I guess the defence team could have argued that the patient is partly to blame, because if he was handed a cup of green liquid, that the vast majority of us would go, hang on, why am I swallowing this? This looks a bit weird and it smells a bit funny. But the other two, one of them's lactulose and the other one's dishwashing detergent. So I wanted to make the point for students that if they can't tell the difference by looking at that photo, which one's dishwashing detergent, that the contributory negligence argument would completely be washed out, because if they look anything like each other, and to be honest, I haven't tasted the dishwashing detergent, but I have tasted lactulose, and it tastes very similar to what I imagine dishwashing detergent tastes like, that it's not that unreasonable that he would swallow it. So in terms of thinking about the defences for negligence, if you look at this particular picture, I think it depends on what colour the dishwashing detergent is that he gave him. And I think it was actually the C one. I think it was a really absurd colour. It doesn't make it okay. It doesn't mean that the nurse didn't do the wrong thing, but you have to ask why a patient would have swallowed that and then suggested that he thought it was lactulose. So anyway, I just think that's an interesting little story as well. Activity 4 is to look at applying civil negligence to other cases. So if you go through this case, the Shah case, with the students, and then get them to do the next two cases as groups, that would be a better way to do it. There'll be group work rather than taking them through it yourself. But we're doing exactly the same process. They're the same questions. You're applying the 4 principles of negligence and having a think about whether they apply in that circumstance. So you've got 2 different cases where you go through the same 4 steps. Then in the last activity is scope of practice. I've allowed plenty of time for it because I want them to get their head around scope of practice well. I've provided an article that they need to download and read. And I want them to go and find it themselves. I've specifically not given them a link so they can just click on it. I want them to go and find that in the library website and to see if they can find some other stuff on scope of practice too, I suppose. But they need to be able to go and find this article and scroll through it. This is a literature search, a literature review, and it's a scoping, integrative review, and it talks about all the different available definitions of scope of practice that are out there and how difficult it is to define the concept. And it's good that it's a learning objective because it's really important that they go through it, but it's difficult for them to achieve this in the assessment item because it is a fairly vague term. We sort of all think we all just understand what a scope of practice is, but if you were asked to provide a definition for it, there's not that many out there and they're fairly simplistic. They don't really answer to the full extent of what you and I would consider a scope of practice. And I found it's an interesting point where students that haven't been out on placement, have no clinical background whatsoever, really struggle with the concept of scope of practice. If you scroll through it, I want them to be able to find this stuff themselves. Part of this is one of those unintended learning things where we're asking them to be able to pull apart a journal article rather than look at blogs and stuff. So I've tried to provide them with some good quality sources as we've gone through the tutorials. And this is one of them. This is a good article. And it talks about the ICN's definition. So the competencies in brackets, knowledge, skills and judgment, professional accountabilities and responsibilities of the nurse, which is quite simplistic but accurate. So that's one example, and then it scrolls through, there's a better one further down. So another definition that's put together by the NMBA. The key definition of scope of practice for Australian nurses emanates from the NMBA, which states that a profession's scope of practice is the full spectrum of roles, functions, responsibilities, activities and decision-making capacity that individuals within the profession are. What a great place to put a table, because then it goes on for pages. Educated, competent and authorised to perform. So in their paper I would expect them to be able to take that definition and pull it to bits and then talk to me about what would be involved in that and how a nurse might be working outside that. So they've been given an example of a nurse clearly working outside their scope of practice and they need to be able to explain how that definition works. So the first part is they need to find that section and then they need to have a really good discussion about what's involved in it. So that's really the point of it. The rest of the paper talks about these themes here. So how scope of practice is very difficult to define and put into a parameter. Talking about how the context of scope of practice is quite different from one area to another. talking about how the concept of boundaries is built into the idea of scope of practice. So these are my limitations, and outside these limitations are where I'm not supposed to go. And so the connection between the concept of boundaries and scope of practice, and also scope of practice and advanced practice. It's very hard to search for scope of practice and not find stuff about nurse practitioners and people in specialised settings. A lot of scope of practice commentary goes towards specific settings rather than nurses in general. Which is an interesting point. So that they've written some stuff about that as well. So it's a really good article. You should suggest that they read this a few times and get their head around it, because it's 1/3 of their major paper when they're sort of writing it up. So I'd strongly suggest they go off towards reading this. Close that. Factors that determine the scope of practice, so they'll find that in the definition. And should discuss it a bit and have a think about the sort of things, so their level of training and where they've done their education and if they move from one country to another and all that sort of stuff. Some examples from searching from the web of nurses working outside their scope of practice. If they're having trouble, you might suggest things along the lines of like hypothetical examples where nurses prescribe things or nurses insert things or perform part of a procedure, in theatres or ED or ICU, places where the lines tend to get a little bit blurred sometimes around what people should and shouldn't be doing. So mention that's just another common example at the moment is the beauty therapy stuff, which is what their case is about in the paper around Botox injections and all that sort of stuff. So ask them to have a look into. They'll probably find some very interesting examples of nurses doing things they shouldn't be doing. And then how is the scope of practice for a registered nurse relevant to the principles of civil negligence? You're asking them to make the connection between you can't really meet your duty of care for a patient if you're working outside your scope of practice, because you won't understand the risks and benefits of the procedure that you're doing properly if you're not authorised to be able to do it. If a nurse goes to intubate a patient but they haven't been trained properly how to do that, then doing that action will put that patient at risk of harm, which falls below the level of standard that we'd expect. So it's the nurse working without a net sort of thing and doing things that they really don't know what they're doing properly, even though they might have a rough idea of what's going to happen. If they haven't been fully trained, they're not fully competent to do that particular procedure. If something's outside their scope, then they're exposing themselves to they're acting negligently, and they make themselves pretty obviously a target for civil negligence. So it's good to discuss those connections between those two things. Anyway, I apologise for my voice. That must have been horrid to listen to. I'm sure I'll be back to human by next week, and I'll record about 3 or 4 weeks for the next video. Thanks, guys.